So thank you for this opportunity to talk. I'm Michael Abouyannis, so I'm a welcome academic clinical fellow. And I'm going to be talking through the True-1 clinical trial. So there'll be some background on the trial itself and the methods, and then some of the early data that's emerged from this phase 1. So I don't need to make this point to this audience. Snakebite has a huge burden, 1.8 million envenomings each year and approximately 100,000 deaths. And as we know, antivenom is often effective, but it does have its drawbacks. So it's an animal-derived product. There's often a high risk of anaphylaxis. It's inherently quite costly to produce. It can't be given orally, it's always given intravenously. The snake species specificity can be quite narrow depending on the product and the group of snakes that are being considered. And it's often poorly available in the places where it's needed most. And so this trial is exploring a chelating therapy as a treatment for envenoming. And actually, we've known for some time that chelators do have an inhibitory effect on snake venoms. So in 1955, there was a paper that described...
Sorry, Michael, the slides are not being shown.
Oh, okay. Let me try and share again. You've not missed too much. Is that showing now?
Yes.
Oh, good. It's is it changing? Yeah. Okay, good. Okay. So yeah, and subsequent to that in vitro identification that EDTA inhibits venom, in 1964, Goucher and Flowers undertook an experiment in rabbits where they pre-incubated venom with EDTA and found that longer periods of pre-incubation were associated with smaller lesions in the skin. And then more recently, this has been looked at from a sort of purposeful translational point of view at LSTM to identify new treatments for snakebite. And the paper in 2019 by Laura Aldulescu screened multiple metal chelators, and in particular looked at products that we knew were already safe to use in human or are already available in humans. And Unithiol was identified as the most promising. So Unithiol is the generic name. It's also known as DMPS, which is the molecular name, or Dimerval, which is the trade name. So it can be a bit confusing. I'll stick to Unithiol for this talk, which is the generic name. And the target of this drug is the snake venom metalloproteinases. So this is a particularly abundant enzyme in snake venoms, particularly vipers. It's in Echis ocellatus, which is a huge problem in West Africa. It's by far the most abundant component of the venom. And as Chema had earlier on his slides, the pathology of this is to cause coagulopathy, but also to damage the lining of blood vessels. And so this image shows thinning of the basement membrane and rupture of the blood vessel as well. And that's why we see bleeding with vipers, and that probably also contributes to the skin damage that we see with vipers. And these enzymes are zinc dependent. And so Unithiol is a zinc chelator, and that's how it inhibits the SVMP enzyme. So Unithiol has been around for some time. It was developed in the 1950s. It was used as a treatment for mercury and arsenic poisoning, and is still occasionally used to treat people with heavy metal poisoning. It can be administered intravenously or orally as an oral capsule. We know at the current doses that are used that it has good safety, and the PK is reassuring as well. So the Tmax, which is the time to reach maximum concentration following an oral dose, is 3.7 hours, but you actually get good levels within about 2 hours. but the optimal dose for snakebite is not known. And because this drug was developed a long time ago, it didn't go through dose escalation studies, and we don't really have a good idea of what a safe upper end of dose is for this drug. And so we adopted a phase 1 design. The trial is therefore in healthy volunteers, and we've conducted the trial in Kilifi County in Kenya. This decision was made because this is an area that's endemic for snake bites, and therefore has a population that are likely to benefit from a drug such as this. And also because it's host to the Kemry Wellcome Trust program, which has a lot of experience with conducting early phase clinical trials. The primary outcome of this trial is safety of increased oral doses, and the secondary outcome is pharmacokinetics of both the IV and oral doses. The sample size is planned to be 64, and they're split into 8 groups of 8. And if anyone wants to know more about the design and methods of the trial, the protocol is published with Wellcome Open, and the trial's registered with the Pan-African Clinical Trials Registry. So for dose selection in this trial, as is often the case in phase 1s, we needed to base this on preclinical data. Now there's in vitro data from a coagulopathy assay that we often use at LSTM, where essentially human plasma is spiked with venom, and you can measure the time it takes for the blood to clot, and then you can add in study drugs and see what concentration of drug is needed to inhibit that procoagulant effect. And from that assay, we estimated that an oral dose of 1,500 milligrams would be needed, which is quite a bit higher than the currently used dose for heavy metal poisoning. From our in vivo experiments, mice were given 600 micrograms of unithiol, which equates to 150 milligrams. But these in vivo experiments weren't dose finding, the mice just all got that dose. But that's reassuring that a lower dose in vivo did prevent mortality in mice. And so given the uncertainty, we started with an oral dose shown at the bottom here of 300 milligrams, which we know to be a safe dose, and then escalated through to 1,500 milligrams. So between each dose escalation, there's a safety review. An independent board reviews the data from the trial and gives us a yes/no decision on whether we can carry on. Following reaching the 1,500 milligram mark, we then paused to undertake an interim pharmacokinetic analysis, which then guides the multiple ascending dose stage. So in the multiple dose, participants receive the drug a few times a day for a period of 2 or 3 days. And this gives us more information about the pharmacokinetics of repeated doses and also the safety of repeated doses. And then separate to the oral dosing, we also have 2 IV dosing groups. So one received 3 milligrams per kilogram, and the second received between 5 and 10 milligrams per kilogram. And that again depends on emerging pharmacokinetic and safety data. These doses, the IV doses are pretty established doses. So there's less concern about monitoring for safety in those groups. And so screening and recruitment for this trial commenced earlier this year in February. We screened 147 volunteers and we randomized 64 to the 8 dosing cohorts. There were 10 females and 54 males enrolled. The median age was 29 years with a range from 20 to 61. And following screening, we randomized at the end of February and then started the single oral dosing stage of the trial. So through March, we escalated through 300, 900, and 1,200 milligrams. And then in early April, we dosed at 1,500. And we had reassuring safety data, which enabled the Data Safety Monitoring Board to allow us to continue as planned. And we also dosed one of the IV groups, so the 3 milligram per kilogram IV group. So at the moment, we're doing the PK analysis and we're getting some data from there at the moment, and we're hoping to have that complete in the next few weeks. We can then model the PK data and design the multi-dosing regime and complete the last stage of the trial. So in terms of the safety data that's emerged so far, so this table summarizes the solicited and anticipated adverse events. So because this is a repurposed drug, there's lots of data on side effects that we expect to see. So these include nausea, weakness, loss of appetite, painful injection site following IV administration, abdominal pain, skin reactions that are often mild but can be severe in very rare cases, raised ALT, which is a liver enzyme, and raised creatinine, which is a marker of kidney function. And so in total, we've had 33 events that were categorized as expected side effects. And all of these have been mild or moderate severity, which aren't concerning. And we haven't had any severe or life-threatening solicited or anticipated adverse events. And then in terms of non-anticipated adverse events, there's been 23 in total. Again, nearly all of these have been mild and a few have been of moderate severity. So these are grade 1 and grade 2 adverse events, which generally aren't worrying and wouldn't cause a trial to be paused under normal circumstances. And we've not had any severe or life-threatening unsolicited adverse events. And there's been no SAEs, no serious adverse events to date. But follow-up is ongoing. But it's good to see the safety data is reassuring so far, and that the higher oral doses seem to be a feasible option. And the reason we really want that is we see this drug being used in rural clinics, so the places where patients with snakebite first present, and they would be well equipped to just give an oral capsule at a higher dose and then transfer the patient to a hospital potentially for antivenom treatment. So the PK analysis is ongoing and should be complete soon. Sort of taking a step back, there's an urgent need to explore therapies such as this that are orally available, affordable, safe, and cross-species specific treatments for snakebite envenoming. So just to finish, I'd like to thank the various people who have been involved. So in particular, the team at the Kemri Wellcome Trust programme and my supervisor there, Mainga Hamaluba, who've worked incredibly hard, particularly during the period that we were dosing participants. And the team at University of Liverpool who are working on the pharmacokinetic analysis, Richard Fitzgerald at the Royal Liverpool Hospital, who helped develop the first draft of the protocol, and the team at LSTM, including my supervisors, Nick Casewell and David Lalu. So I'll end there, and I'm happy to take any questions. Thank you.
Do we have any questions in the audience? Yes, we have two. Okay.
Thank you, Mike. It's very nice to see the results of the phase 1. One small question, because you have indicated that all events were basically mild to moderate, but in relation to the creatinine specifically, because you had a creatinine elevation in the 900 and 1200 milligram, 1200 and 1500 milligrams, and I was just wondering if it was grade 1, 2, if you could specify, because you have not seen with the lower.
Yeah,
groups.
they were grade 1. I'm pretty certain they were both grade 1, and they both spontaneously resolved, so they didn't require treatment with intravenous fluids or anything like that. So yeah, we're not sure whether it was the drug can cause some dehydration because it's excreted renally, so it may be that it's pulled some water through and has caused some mild dehydration. But yeah, but it wasn't concerning. Thanks.
Hi, good presentation. In terms of these window of opportunity, in terms of using a drug like that, is there a stage beyond which you know, the chelating effect is not going to really sort of benefit the patient.
In terms of the natural history
Yeah.
of the disease.
Exactly, yeah.
Yeah, I think that there definitely is. I think it depends on which bit of the pathology you're thinking about, because I think with coagulopathy, sometimes you've got quite a bit of time, and patients will often have, you know, can have a prolonged period of coagulopathy that will still respond to treatment. I think with the skin damage, you've probably got a lot less time, and I think once skin damage has happened, you know, obviously a drug like this can't reverse that. It's just there to stop it from further developing.
Okay,
So I think,
thanks.
yeah, which I think is part of the reason that these treatments are potentially of benefit if we can cut the time to presentation down and get treatments in early that stop skin damage.
Thank you. Enjoyed the talk. It's nice to see it get to this stage. Questions more about what you're going to do in phase 2. So you've got a single multiple ascending dose, but you've got no efficacy readout, and there's not a great deal of difference in terms of adverse events. So how do you decide what to do in phase 2? What's your thinking there?
Yeah, so there's I guess a few ways we could go with it, and I don't think we've decided yet. We could just use the higher dose and do an early proof of concept to see if there is an efficacy signal and if it's worth exploring further, which may piecemeal the trials a bit, and we may end up needing, you know, like a 2A and a 2B, for example. Or we could do a dose finding more like a phase 2B and randomize to different doses and try and understand the relationship between efficacy and dose. So yeah, we don't know, and yeah, we have started discussions on the design of the phase 2, because we've got, we think, enough data now to think that it's feasible, that will be the next step. But yeah, in the early stages at the moment.
Thanks, Mike.
Okay, thanks.
May I ask a question? Mike, I have a question.
Oh, sorry.
Sorry. Well, thanks
go
for
ahead.
thanks for your presentation. My question is whether in the pharmacokinetic analysis you will be able to detect whether this component is reaching the tissues, the extravascular compartment. Would that be feasible from the pharmacokinetic analysis?
Yeah, I'm not actually sure on that one, in terms of, I mean, we're obviously not sampling the tissue, so we won't have a direct read. Whether compartmental models will allow us to make some assumptions about how many compartments the drug is diffusing into. But my understanding of the PK and how the modeling will work isn't good enough to be able to answer that. Yeah.
Thank you.